To say thank you very much, everyone, for the outstanding attendance. Great to see you all, and thank you for your time and energy yesterday. I trust everyone's feeling a little bit upset with regards to the result last night. However, I think we can all say that they did the best that they could, and no one ever expected them to be in the finals. And for it to go to the 11th inning last night, well, yeah. So today we've got another busy agenda, and first, without further ado, I'm going to introduce you to Andrea Jolovic, who's a genetic counsellor. And on that note, I'll hand you.
Great, thank you. I don't think I need this one. I'll put it down, yeah? Oh yeah, okay, great, it works. Oh. Thank you for breaking the ice with the Blue Jays. When they first invited me to come, I was like, 9:30 on a Sunday morning after we've all had an extra hour of sleep. It's gonna be amazing. And then I think nobody got the extra hour because we all stayed up watching the game, so never mind. We all got normal hours of sleep. My colleague Chantal Morel couldn't make it today. We both came down with like something. So she's still struggling, but I think I've crawled out of it. So be safe out there. It started, it's the season. You can progress my slide, I think. I'll do one more. So what I will focus on today is, I guess I should have read my title out loud, but I was just diagnosed with amyloidosis. What should I tell my family? I am a genetic counselor. I meet with families from in various situations. So families that have had a genetic diagnosis, families that are looking for a genetic diagnosis, families that have had a genetic diagnosis and want to know a little bit more, that want genetic testing, others that do not want genetic testing but want to learn more. So the outline of today will be really just to talk about genetics a little bit. We'll talk about the role of the TTR gene, and I'll go into more detail there. I'll talk about genetic changes, sometimes known as a mutation in the TTR gene, and then I'll talk specifically about hereditary TTR amyloidosis. Next slide, please. So really what we have here is bringing us back to biology. If you took a pinch of skin, you looked at the skin cells under a microscope, and then you zoomed in even closer, what you would see in the very, very center, well, you can kind of see a picture of a cell, and then if you zoomed in to the center of the cell, you see those X-looking structures. That's called a chromosome. A chromosome is the carrier of our genetic material, okay? So our genetic material is found on our DNA. So if you take a chromosome and you unwind it, it's just DNA. And then DNA is what carries our genes. So hair color, eye color, how tall we are, everything is coded by genes. And there is specifically a gene called TTR. And then if you take the DNA strand and you squish it back into its smallest container, that container, once again, is a chromosome. So I'll go to the next slide. The picture on the left is what chromosomes actually look like under a microscope. So they're just kind of all over the place. The body doesn't care where they are. The body just cares that they're all there. And specifically, actually, just press next one time. Oh, my slides are going to be annoying. That little arrow is where the approximate location of where the TTR gene is found. It's on chromosome 18. So as humans, we have 46 chromosomes total. They come in 2 pairs. What I want you to know is that in each pair of our chromosomes, number 1 all the way through to 22, we inherit 1 copy from each of our parents. So we got 1 copy from our mom, we got 1 copy from our dad, and then when we go on to have children, we pass on 1 copy to the child. Our partner passes on the other copy to the child, giving the child the full set. Next slide, please. Just when you hear me finish like the point, just next it. It's okay. Or you know what, just do the whole slide. I think yeah, perfect. So like I said, the TTR gene is found on chromosome 18. We have 2 copies of this TTR gene. 1 we got from our mom, 1 we got from our dad. And this gene makes, I don't have my glasses. This gene makes a protein called transthyretin. It's a protein, it's a transport protein. What that means is that it's mainly produced in the liver, and it transports 2 types of molecules. One is called thyroxine, it's a hormone, and the other one is called retinol, a vitamin derivative. And so the liver, it's mostly produced in the liver, but it's also produced in a part of the brain and a part of the eye as well. Next slide. So normally, I just wanted to show you this. I'm not going to go into too much detail, but the TTR gene forms this protein, and when it's stable, it's this 4-part tetramer that you can kind of see in that second part. So you see the liver, and then you see the 4 different colors, purple, pink, blue, and orange. And when it's stable, that's what it's supposed to look like, and it's just transporting molecules, and that's what it's supposed to do. However, when there's a genetic change in the TTR gene, it makes the structure of the tetramer less stable, and it breaks down. And it's the breakdown into these single monomers that our body can't break down. And it's the accumulation of these single monomers in kind of towards where it's just the little like single blue guy. It's the accumulation of these that causes the amyloidosis, which is progressive because over time the body accumulates more, and it mostly affects, as you know, the heart and the nervous system. I'll go on to the next slide. So we've been talking a lot about genetics, of course, already, but I'll preface this by saying that there are 2 main types of this TTR amyloidosis. The first is the hereditary one, which is what I'm going to continue talking about. It's inherited, or it's caused spontaneously in one person for the first time. And the typical age of onset can be very variable here. So it can be as early as presenting in the 20s, or as late as in the 7th decade, in the 70s. There are specific variants within this TTR gene that I've been talking about that can predict within like 10 to 20 years age of onset, okay? But again, it's still a big range with the inherited type, with, of course, the earlier onset being much more obvious. The common symptoms are within the nerves, the heart, the eye, and the GI tract. And 10 to 20% of all TTR amyloidosis is genetic, okay? So that means 1 in 5 people diagnosed with this specific type is genetic. 4 out of 5, it is what is known as the wild type, meaning that it's just age-related misfolding, and there is no genetic cause identified. Also, the way that it presents with the later onset at greater in the 6th decade, and also just mainly heart involvement. Canada is considered, I'm sorry if this is a little small, but Canada is considered a non-endemic region for TTR amyloidosis, which means that there isn't, it's also sometimes known as a founder mutation, where in certain populations we see a condition that is caused by a genetic change happen more often in one population than we do in other populations in the world. So Canada does not have this founder mutation, or is not an endemic to having mutations in the TTR gene. The 2 bigger locations are Portugal and Japan, but there's also some endemic regions in Ireland, French Canadian, West African, and Scandinavian ancestry. What we see now, so I've been saying 1 in 5, and I think it's probably going to stay that 1 in 5 genetic subset for a while, but with better testing, and not just genetic testing, but I mean cardiac imaging and imaging, blood work. With better diagnostics today, we may see more genetic causes of TTR than we were before, just because we're better at picking it up earlier. Next slide, please. Just one more time. One more? Oh, I had a picture. Okay, I have a picture of inheritance on here, and I guess it's not transferring onto the slide. But again, bringing us back to biology, I just have a picture of 2 people and then 4 outcomes of their children. Yeah, okay. I'm seeing some nodding. So basically, TTR is considered autosomal dominant, which is what the picture should be up there, which means that when somebody is diagnosed with a genetic cause found in the TTR gene, there is a 50% chance of passing that altered copy down to the next generation. Knowing a genetic testing result or identifying a genetic cause can help family members who could be affected, because we know there's a 50% chance, whether they're clinically whether they're already presenting symptoms and now they know that if they got tested, that would probably be an answer for their symptoms if it's already in the family, or there are sometimes asymptomatic individuals as well. So sometimes people who have had no symptoms present, but they have a family history of it, they can get genetic testing as well. Genetic testing provides options for monitoring or preventative treatment to those that are at risk. So those who maybe have started some symptoms get genetic testing, and then it can help streamline their diagnostic pathway and their treatment pathway. Otherwise, those who are asymptomatic today, who have genetic testing, can get put into a preventative pathway faster. But also, genetic testing removes any unnecessary treatment or like management options for those who are identified not to carry the variant. So families sometimes decide, I shouldn't say families, sometimes an individual might decide they don't want to be tested, they don't want to know, but they're just going to monitor for symptoms, they're going to see, their multidisciplinary team more often, but having a negative genetic test in that person would mean that they no longer have to do anything. They're not at risk of inheriting, they're not at risk of developing symptoms of the condition. Next slide, please. Okay, so looking at testing, discussing the option of testing in families is important because early diagnosis can help complications or can help prevent complications. Relatives can speak to a genetic counselor or a medical geneticist, which is my colleague that couldn't make it today. What I want you to be aware of, and like this is like my biggest take home, is meeting with a genetic counselor or meeting with a medical geneticist does not mean you have to have genetic testing at all. It just means that you have the option to talk about what's going on in the family, kind of have a file ready in a genetics clinic, and then decide whether genetic testing is right for you and your family or not. I'm gonna repeat that like 5 more times. But looking at different types of testing, which is what I was touching on earlier, there is genetic testing, of course, which confirms whether a TTR variant is present or not. Then there's the testing associated with imaging or biopsy, which can show these amyloid deposits. And then there's blood work or nerve and heart studies, which can measure the impact on the organs with the amyloid buildup. Next slide. And so this is what I was touching on. Adults can choose to be genetically tested after genetic counseling. And there's 2 types of testing in genetics. So there's the diagnostic testing, which is when somebody presents to a clinic with symptoms, and the genetic workup at that point tells us what genetic testing to arrange, and that's considered diagnostic. Or it can be diagnostic when somebody tells us, my mom or my dad has this condition, and now I have these symptoms. And so for us, we call that also diagnostic testing because there are symptoms present. There is also the option of predictive testing. So this is offered when there is a known familial variant in the family, and this is offered to those who have no symptoms today, okay? Predictive testing is basically telling people whether they're at risk of developing the condition or not. And here it is, I bolded it. Meeting with a genetic counselor or medical geneticist, it doesn't equal genetic testing. And that's really, really important because sometimes people don't want to engage with us because they think that they just have, like they're coming here to meet with us and they're getting their blood drawn right away. And that's not what we do. I also tell people the wait list in Ontario, are there people from outside of Ontario here? Yeah, okay. Oh, where's everyone from? Nova Scotia? Okay, Nova Scotia's a little rough too with genetics. Newfoundland? Okay, so we basically have everyone. Okay. I don't know if any province is better than another. We're basically Canada. Waitlists are really long. Has anyone experienced like a genetics clinic waitlist here? Yeah. 8 weeks? That's like amazing. Where did you go? Oh. Yeah. Well, okay. Well, I'll talk to you after because that's usually not the story we hear in Ontario. It's usually a lot longer to get an appointment. Like, I'm talking years. No.
Well, our cardiologist arranged it. It was like days.
Did your cardiologist arrange your genetic testing and came back positive or negative? Okay. And then, but then you still saw a genetic counselor. Melanie, okay, this is unheard of, but okay, it's fine. It's really unheard of to get seen that quickly across Canada, but that's amazing, and that cardiologist is incredible, and you should share that information. But why I kind of am saying that is, if you are interested, or even if like part of your brain is like, maybe one day I want to know maybe one day I want to get genetic testing, start that process now. And if if your appointment shows up, go to your appointment, and then you have a file. And I say this for all conditions. I don't say this just for this. Like, have a file in a genetics clinic, because once you're their patient, it's really easy to get back in, and you don't have to make any decisions like on the spot with testing or not testing or anything like that. But that's amazing. And I know Melanie very well. She's great. Okay, I'll do the next slide. Oh, sorry, it's okay, you don't have to go back, but I'll just touch on one point. Prenatal or pre-implantation genetic testing. So family planning is something we talk about with genetic counselors, and what we talk about is, we basically talk to you about like what are your goals with your family, with growing your family, and we can kind of try to see what options are available today to fit with that. I'll go into a little bit more detail. So this is Ontario. I'm not familiar with the other provinces, but if you have any questions, I'm happy to figure out kind of what's going on. So because specifically TTR amyloidosis, the symptoms of the condition can look like or are also similar to symptoms in other conditions, there are different ways that you can have a genetic testing panel done. So for example, UHN has an amyloidosis genetic testing panel. So TTR, the gene, is one gene within the 7-gene panel. There's 6 other genes on that panel. CHIO does what is known as a pan-cardiomyopathy genetic testing. Obviously, TTR fits into that because of the cardiomyopathy. Then you can just do single gene testing. So if a doctor is like, yes, this is the diagnosis, I'm very confident, they can literally just test for the one gene, TTR. They can do that in Kingston or London in Ontario. Again, it depends on like where you live. That's usually where they send your sample. But then also London Health Sciences has a Charcot-Marie-Tooth panel, which is really large. It's 88 genes. And of course, TTR gene is one of the genes, but because of the myopathy and some of the other, there's actually quite a bit of overlap. There can be a lot of overlap with Charcot-Marie-Tooth, so sometimes physicians order this panel to kind of catch the widest net of possible genetic causes of symptoms. Okay, next slide. Okay, so how do you prepare for a genetic counseling appointment? The first thing I tell everyone is prepare or have a lot of information about your 3 generations. So if you're kind of in the middle, kind of have the information about the generations below you as well, children, grandchildren, and then also above. But 3 is sort of the minimum that we ask for. And if there's anyone in your family that also has any signs or symptoms of anything, that even if you're like, oh yeah, my grandfather maybe had like a foot drop thing, that maybe, there's a narrative in our family that there was this, share that with your genetic counselor. If you can, the age of onset of any symptoms, even like, I think my grandfather had it when he was 50 to 60, or my dad when he was 50 to 60. Like, any information helps. The type of the symptoms that you're aware of, age that any family members passed away, if that's applicable, and any other health conditions that present in the family. Sometimes when we meet with families, they think that the condition that they're aware of is just the way that their family presents. So maybe there's only just cardiomyopathy in their family. And so they don't tell us about other things that happen because they're like, oh, maybe that's not applicable. Just tell us everything, honestly, and then we can kind of decide what isn't applicable. Specifically, even if there's any history of cancer, I know that's not necessarily related, but you're in front of a genetics person. Just tell them everything, and then there might be something else. There might be something else that they want to talk to you about as well. And then, very importantly, if there is a known genetic cause already identified in your family, please bring a copy of that actual report to your appointment, or have whoever's referring you to genetics include that in your referral. That will save you so much time, and yeah, that will save you a lot of time. Even if it's a negative report from a family member and you're approaching genetics for the first time, you can bring that negative report in with you. Appointments are usually an hour long, and I say, as you're coming up to your appointment, think about some questions that you might have, write them down. It's an hour, so you have a lot of time to just really get to the bottom of whatever it is that you're thinking about or kind of figuring out a best approach for you and your family. I won't go into the symptoms. Okay, I'll go to the next slide. I am not the best person. Can you go back one slide? Did all my pictures fail? Yeah, all my pictures failed. That's okay. I'll go to the next slide. Okay. So what I did have is a picture of the same pathway I showed you earlier of, the liver producing the tetramer and then kind of how it is unstable and how it breaks down and then it accumulates. And then what I should have had is where each of the different therapies kind of fall into that pathway. But I'll just speak to them a little bit. Again, this is not my area of expertise. I don't have my glasses and I can barely see my screen. I'm not gonna be able to see that. Okay, so I'm not even gonna go into this. We're just gonna next it. I'll go next slide. Okay, so talking points for your family conversations. This is just a little bit of brainstorming. I always tell people, however you've approached or problem solved a difficult decision in the past, whether it's buying your first house, selling your house, buying a car, whatever hard, big decision you've had to make, approach that, or the way that you approach making those decisions, approach genetic testing or even just accessing genetic counseling. Whether you're an Excel person, whether you like to talk one-on-one to everybody that is important to you, whether you like to sit the whole family down and talk to them all at once, whatever it is that you do in other big life decisions, kind of treat this the same way. But just some talking points for family conversations. This is genetic, we can test for it. Again, if it is genetic, we can test for it in your family. There are treatments that slow or stabilize the disease. You don't need to rush, that's the big one. There's time to meet with a genetic counselor with the preface that there is a really long wait list, usually. And of course that we're not alone, that there are so many people that are experts, literally here, that can support us, that we can learn from, that can share information. And of course, I've shared the TTR Amyloidosis Canada and then the Canadian Amyloidosis Support Network as well. Okay, I'll do the next slide. So family planning can be discussed with a genetic counselor. So what I mean by this is if there is a identified genetic cause of the condition in your family, there are options for you or your family members to discuss. Again, I just say go in and get all of the information, and if you hate all of the options, at least you've known them all ahead of time and you made your decision knowing them. The first one is some families, not that I've seen with this condition, if I'm being honest, but there are families who do prenatal testing. So they know that they're affected themselves, okay? And again, this is usually the earlier onset families when we're looking at somebody diagnosed in their early 20s, 30s, sometimes 40s, and they're growing their family. They may decide to do genetic testing in a pregnancy to just know if the pregnancy is at risk or not. But again, it's not very common in the condition. There is something known as postnatal testing, where families do genetic testing after. Again, very uncommon with this condition. It's usually that we wait for children to be of age to consent, so 16 in Ontario, in Canada, that they can make the decision themselves whether or not they want to be tested. But the one that is an option that more families today are taking up across a lot of different conditions, I'll go to the next slide. It's called preimplantation genetic testing. There are pictures. This is like my best picture. Okay. There are little circles. Picture a cell, okay? And I actually really like this picture, so I'm kind of sad this one didn't show up. Picture a circle, okay? It's a cell. It's actually an embryo. An embryo is what families, there's IVF, is kind of the first step to this. So what families can do today is they can actually genetically test their embryos before they transfer their embryo. More and more families are deciding to do this when there is something in the family. And I'm not just talking amyloidosis, I'm talking like everything. Certain conditions we see it more often than others. But basically, people do IVF, they create their embryos, and then we take a really small biopsy of about 5 to 10 cells, and that biopsy is what is sent off for genetic testing. And then families know, okay, I have 10 embryos, and of my 10 embryos, it's 50-50, but 50-50 per embryo. Okay, 2 of my embryos are affected. I have 8 embryos I can transfer that would be expected not to be affected, or I have 4 embryos that I could transfer, whatever that is. So families are taking this option up more and more. Again, this is typically for really early onset conditions when we know that the presentation has happened before these families are growing, right? So we're talking 20s, 30s, 40s. Okay, I'll skip to my take-home message. Next slide. So knowledge overall empowers families. Like I said, 4 out of 5 times the presentation in a family is not genetic. 1 out of 5 times it is, approximately. Testing can guide care, it can guide treatment, it could guide prevention. So if you are tested and you come back negative, then you know that the risk is really reduced for your next generation. But also if you're tested and it comes back positive, then you are aware of, hey, maybe my siblings, maybe my children, maybe that story about our family, now it makes a little bit more sense. Genetic counseling supports you and your loved ones really, honestly, every step of the way, from pre-test, during testing, and then after you have your results back. And then again, meeting with a genetic counselor does not equal proceeding with genetic testing. You can absolutely decline having genetic testing at the end. And then what I'll ask is, could you go back to my very first slide? It has my contact details, and then I'll just see if there's any questions from the audience. I'm really sorry about my pictures. I don't know what happened. Sorry.
Thank you so much for that presentation. During the presentation, it occurred to me a number of mutations can produce amyloidosis. And amyloidosis is the misfolding of these TTR proteins. But it's been shown that different mutations tend to present differently. Mm-hmm. Do you have any insight into what that mechanism is?
It goes back to the way that okay, so imagine that a gene is like a recipe book, okay? Or a single recipe. And where the genetic change happens, the spelling, okay, let me start again. A gene is like a recipe, okay? If there's a typo in your recipe, and I'm talking you're gonna make apple pie, and instead of apple, it's potato. But everything else is the same. So the sugar content, the crust, everything else. You show up to like Thanksgiving or Christmas or whatever with your potato pie, and everyone's gonna be like, oh, this isn't what I wanted, okay? That could be like, but you still got a pie. So that could be like a more gentle type of a mutation, okay? Then there are other variants of your recipe where like it happens so early on, like very early on in the recipe, maybe the recipe just stopped printing. And so literally you were just told to preheat your oven at 400 or 425. I've never made a pie, I don't know. You preheat your oven and then it stops. Like the recipe just no longer works. That's a much more severe presentation because now you're showing up to Christmas, Thanksgiving dinner, whatever, and you have no pie. So the mechanism of the genetic change or the mechanism of the specific mutation having an impact is really like, what is the mutation? So there are these mutations called stop mutations. They happen really early in the gene, and basically the gene just stops work. The protein, the gene's telling the body how to make a protein, the protein just stops really early on, and then it doesn't even look the way that it's supposed to look. That's sort of one way that it can be presenting more severe earlier on. So I would say the mechanism behind it is what the mutation is and where in the gene it is found. So there's a really common mutation. I don't know it off the top of my head, but it is found in the Portuguese population, and a different mutation is found in the Japanese population. And both of those are much more severe in the sense that they present way earlier on. So the way that the protein misfolds, the way that it aggregates, just the presentation is a lot faster, and we see symptoms a lot earlier. And it is to do with where the mutation is found in these families. Did that answer your question? A little bit.
Hi. Hi, good morning again, Andrea. Just wanted to ask, you had mentioned earlier on that in terms of genetic counselling and testing in Ontario, and I've heard it firsthand from several patients, they were told it would take a year, 18 months to actually get to that process, to have access to it. In terms of yourself and your organisation, and I'm not asking for an exact time, but roughly, what are the wait times to see a counsellor? And secondly, you're obviously a private organisation. There's obviously a cost involved. Is that cost excessive? And would it be covered under, for example, OHIP in Ontario? And I apologise for the multi-tiered question,
no, that's okay.
But I think it's something that people will be thinking about.
Yeah, okay, so I am the founder and the CEO of Genomacare. We are a private genetics clinic addressing the waitlist that, what's your name? Carol, the waitlist that Carol did not experience. So basically we're a virtual clinic. We do see patients across actually Canada. So we have clinics referring to us from Newfoundland, not just for amyloidosis, by the way, like we're just a general genetics clinic for everything. So we have patients coming from Newfoundland, a lot from British Columbia, some from Alberta, some from Nova Scotia. So we're virtual. The wait list to see our clinic is, I would say, somewhere between 1 to 2 weeks when we're not really backlogged, and then it can go up to like 4 weeks to see our genetic counselor. The way we work is your first appointment with your genetic counselor is really just an intake. So we ask all those questions. Like we take the full 3-generation history. We talk to you about kind of what's going on for you. What are your goals? What are your questions? And then if genetic testing is, if you're eligible from our intake for genetic testing, we actually do that genetic testing through OHIP. So we pick one of those labs. If you're in Ontario, we pick one of those labs and we offer it to you. So there's no additional fee. But the fee to meet with us is today $500 plus tax, and that's just to become our patient. Like the whole family kind of gets put into that one fee, and then sometimes there's like a small admin fee to arrange genetic testing for other family members. But really we're just trying to like cover our genetic counselor's time, because OHIP, we don't get reimbursed for our time by OHIP. And then again, across the other provinces, we have had success navigating the funded genetic testing landscape in other provinces sometimes, but it's really hard for us to figure out how to get it funded, like how to use your health cards in other provinces. So sometimes families are just like, you know what, we'll just pay out of pocket for genetic testing. So Ontario definitely has the advantage when they partner with us, but we have made it work with other families in other provinces. So if private genetic testing is sort of the way that families want to go, that can cost, I'm just going to quote like the at high end, $1,500 US, okay? And that's just payable directly to the lab. We work really, really hard to find the most affordable option. Like if we're like, we are very confident you only need this small panel of genes, we're going to only offer you that, and then that'll save you money. But yeah, so Ontario, typically just fee to become our patient, and then genetic testing, we can access funded. If you are not eligible for whatever reason that I can't think of right now, but if for some weird reason after an intake with us, we don't deem you eligible for the publicly funded OHIP panel, I don't think it's ever happened, but if we don't deem you eligible, we offer you private as well. So some families, even if they're not eligible for a condition of testing, they just want to know. They just want to do genetic testing, and then that's the $1,500 US again. Yeah.
I have a question for you. When you were talking about inheritance, one comes from the father, one comes from the mother. I believe you also said something about spontaneous occurrence.
Yes.
So can you explain that, and is it still happening, and is it like how often are diseases spontaneously being discovered to have new variations?
Okay, so with the TTR gene, it doesn't look like there's a there's a known, it's called de novo, and I couldn't find a known de novo spontaneously occurring rate. So if anyone has it in the audience, like let me know, but I couldn't find it. So what that means is, right now we don't know how often the gene just mutates by itself for the first time in somebody. There are other genes with other genetic conditions that are almost like hotspots for mutations, and this TTR gene is not. So we don't know is the answer for how often. But yeah, that's what happens when we test, there's a person in front of us, they're like, there is no family history of this at all, anywhere, and they are the first. It has happened for the first time, yeah. Oh, you have to switch on. I think there's a button.
So you mentioned variant and you mentioned mutation. What's the difference?
Thank you. That's a good question. I should be more consistent in my speech. They're the exact same thing. No, it's a really good question. So a variant is a genetic change, okay? So kind of like how I was saying, a recipe, you're reading a recipe, that's how genetic testing is done. They literally start at the beginning of the gene and they read the gene from start all the way through to the finish. And if they find a spot where it looks like there's, the code is just slightly different, they call it a variant of the base that they're doing genetic testing off of. But variants can have different meanings. So like a variant can be considered likely pathogenic or pathogenic, meaning, okay, the knowledge we have today, where the mutation is found in the gene, we suspect that this will cause disease. And that's a variant with the definition likely pathogenic or pathogenic, and that's called a mutation. So likely path, mutation. So those are two variants, but you can have like benign variants that are just totally, it looks a little different in the code, but actually it's not causing disease. It's just, we're all different.
Small v.
Yeah, the chill V. So yeah, sorry. So variant and mutation are the same.
Thank you very much. We have a question which comes back again from relatives, and they want to know. We offer them. You could be tested to know if you might be at risk to have the same disease as your father or mother. One question they have is that, okay, if I accept to be tested and it comes back positive, I'm still very young, and I want to apply for life insurance. Mm-hmm. What are the consequences? Do I have to declare it? Mm-hmm. Or if I don't want to be tested, do I still have to tell the life insurance that my father or my mother has been found with this disease?
We get that question a lot too. Okay, so I'll break it down I'll do the first part. So in Canada, there is an act, it's called GINA, and the act, it hasn't actually been challenged by the Supreme Court yet. So it's like, it's supposed to protect us from health insurance making decisions on our coverage based on genetic testing results. So they're not allowed to ask you for your genetic testing results. However, they do ask your doctor's office for your medical record. If your medical record has a genetic testing result and your office, your family doctor's office, doesn't remove it, then your insurance company will have access to those results. But they're not allowed to ask for it. But they're also not allowed to, it's not supposed to impact your health insurance or life insurance, both actually. But in practice, I don't actually know what that looks like, okay? For the family members that are declining testing or deciding maybe they don't want to be tested and asking about family members, you actually do have to disclose the history. That part is not covered, that part isn't protected, but your genetic testing results are supposed to be safe. Okay, is that kind of what yeah.
Thank you. Thank you. We have some clinical trials right now, the Magnitude study, which is going to change the genetic structure. If one had that done, does it change the hereditary properties? So in other words, if I had the CRISPR-9 technology, would then I have a less likelihood of passing on that gene to my children?
Where is it like a directed CRISPR-9? Like, are you just doing like the liver? Like, are you just focusing on an organ, or is it like when is the treatment?
I think it's going to attack the question was more general too. Can we do genetic modifications to take away the risks from disease? Are we there yet in science?
No. Okay, so today we're not. Basically, the sperm or the egg cell would have to not carry the mutation in order for it to not be passed on. So the CRISPR technology, the ability to fix the gene would have to happen like so early on. There are technologies today that are like gene therapies for specific organs, like the eye. Okay, there's a condition called retinitis pigmentosa. I think it's CRISPR, where they can treat the eye, the genetics in the eye, and that helps treat the actual presentation of the eye condition. Okay, but that person would still pass it on to the next generation because it's in their gonads, it's in their sperm cells, it's in their egg cells.
You answered my question because it goes for the liver.
Okay, it goes to liver?
It's too far down the process. Thank you.
Exactly, yeah. Okay. Okay, well, it was lovely to meet everyone. Thank you for having me this morning. Thank you.